25 picomoles, which comes to over 3.2 nanograms. AFC is higher, and there has been a previous hyper response on stimulation. So whether there is underlying PCOS or not, she could be having absolutely regular menstruation with ultrasound features not suggesting PCOS, yet she could be a hyper responder because her AMH is high. And she did respond, she did have a hyper response in the previous cycle. A normal responder is a lady again with regular cycles, normal built, age less than 37, FSH less than 12, AMH between 10 to 25 picomoles, or if we talk in nanograms, 1.2 to 3.2 nanograms, AFC 7 to 11 per ovary, and previous normal response on stimulation, conventional stimulation. And the third group, which is our interest group, is the poor responder. Who is the poor responder? When we look at her, she has either regular cycles or starts with shortening of cycles, maybe obese, maybe normal weight. Age is generally on the higher side. FSH is generally more than 12. AMH is less than 1.2 nanograms or 10 picomoles, and AFC is less than 6. And previously had a poor response. And in those days, poor response was when you got less than 5 oocytes. Having said that, if you see, is poor ovarian reserve different from poor ovarian response? Yes, it is. We have realized in the last few years that poor ovarian reserve and poor ovarian response can belong to two absolutely different group of patients. A poor ovarian reserve would be when all the tests for ovarian reserve show a poor reserve, like low AFC, low AMH, high basal FSH, and age high, which translates into poor response on stimulation. On the other hand, poor ovarian response could happen to anyone with a normal reserve, with a high reserve, to a young woman or to an older woman. All ovarian reserve tests show a normal ovarian reserve, but on standard stimulation for IVF, the response is poor in terms of number of oocytes collected. So when we say we are doing ovarian stimulation and the patient has poor reserve and we get a poor response, it appears okay. It appears right. But if she has normal ovarian reserve and she has a poor response, then we say, no, this is not right. Something has gone wrong. So this is what we are looking at, what to do if the patient has poor ovarian reserve and poor response, or she has normal ovarian reserve and poor response. A lot of research went into the world of reproductive medicine in the last 6, 7, 8 years. And it was found that if we look at cumulative live birth rate, it is strongly influenced by oocyte number. Now, if you look at this diagram, then you see if we get 1 to 3 oocytes, which is a poor oocyte number, the cumulative live birth, whatever age has been adjusted, is around 20%. When we move to a little more number of oocytes, 4 to 9, we could get at least 40% pregnant. And you look at the p-value is significant when we move from 3 to 1 to 3 to 4 to 9. Similarly, when we move to a normal number of oocytes, which is today considered 10 to 15, again with a significant p-value, then we could have a 50% cumulative live birth. And when I say 50% cumulative live birth, please keep into mind that these patients generally have 1 or 2 embryos transferred, and all the number of embryos which have been generated in the cycle has to be used to say that cumulative live birth is this. The first live birth happens, then we just stop over there and calculate the cumulative live birth on the first live birth of all the embryos which have been collected. And similarly, we have high number of oocytes higher than 15, then the cumulative live birth goes up to 61.5, which is again statistically significant. And therefore, they have been able to classify patients on the Poseidon criteria, that because everywhere when we increase by 1 oocyte also, the pregnancy rate, cumulative pregnancy rate goes higher. So they've looked at that one change in figure, like 1 to 3, then it becomes 4 to 9, and then 10 to 15, and more than 15. So this is what happened when they saw that the higher the oocyte number was, higher was the cumulative pregnancy rate, and this is age adjusted. So they've taken into account that when they compared, they looked for women who were less than 30, women who were less than 35, women who were less than 37, 40, and then made a whole chart of the whole data. Similarly, if we want to have one euploid blastocyst, how many embryos will we need at whichever age? So here, this color signifies 1 to 4 embryos. This is 5 to 7 blastocysts. They are only talking about blastocyst in terms of embryos. And the light violet is 8 to 10 blastocysts. If a woman is young, 32 to 33 years old, and she has 1 to 4 blastocysts, she may have 1, she may have 2, 3, or 4. There is a 80% chance that one blastocyst will definitely be euploid. But if we move to the other side, if the woman is 40 to 41 and she has just 1 to 4 blastocysts, there is only 35% chance that one blastocyst will be euploid. A higher number is not there in women over 40. Say 8 to 10 blastocysts are never created in women who are more than 40, generally in one cycle, and hence they've not considered that number in 40 and 42 plus women. This is all Caucasian figures where the ovarian reserve is generally better up to 40, and they do make more blastocysts, but with increasing number of blastocysts, there is a higher chance that you will have one euploid. But as the age is less, then you will have it with less number of blastocysts. If the age is higher, then you would need more blastocysts to have one euploid blastocyst. So when we look at oocytes, we see more oocytes, we have better cumulative pregnancy rate. If we see embryos, then we see that to get a euploid embryo, you need more embryos. So the whole concept of the low prognosis group, which was classified as Poseidon classification, coined by Elvigi and Anderson, came up because by the number of oocytes and embryo created in these women. So what they did, they divided all women into 4 groups. The young and older ones with adequate ovarian reserve are group 1 and 2. And the group 3 and 4 is the poor ovarian reserve women. Either she's young or old. Now, if you are asked which one would you like to take up for treatment, if I'm asked, I would say I would want to take group 1 and 2 because here I know that the ovarian reserve is okay. I might be able to correct my previous stimulation and get more embryos. So, and out of 1 and 2, 1 is the best because she is young. Even if you get, say, 8, 9 oocytes, you may be able to produce enough embryos to lead to a 1 live birth. So, the adequate ovarian reserve is the group which needs correction, which is unexpected, and where we just sit with our hands on our head thinking, oh, wow, her AMH was so good, her AFC was so good, she was young, and she's just making 2 dominant follicles, and when we take out her eggs, we find 2 or 3 oocytes only. So these are the women who leave us speechless. We have to give an explanation to our patients and tell them that this could happen and correct wherever we thought is going wrong. Whereas in the other two, the poor ovarian reserve, we already tell the patient, counsel her that, see, your reserve is too little. We might need multiple cycles to gather enough oocytes to make adequate blastocyst for your age. And hence, the patient is mentally prepared that she will have less number of oocytes and less number of embryos. So let us see. All our tests depend on a biomarker. What are the 2 biomarkers we are looking at in our practice today? The antral follicle count and the AMH levels. Now, a valid biomarker should be highly sensitive and highly specific. What does this mean? It means if I say that I will not take any patient with a AMH value below 3 picomoles, because below this, I will not get any oocytes. And if truly it happens in all patients across the board, that if she has 2 or 1 picomoles of value and no oocytes are retrieved, then it is a true positive. That means we got a correct information by the cutoff we used. But if we even get out of 10 in 2 patients, a number of oocytes which we were not expecting, then it becomes a false positive. That we are saying that, below 3, we will not take any patients, but we've left out on 2 patients who would have made so many oocytes on stimulation. So a valid biomarker should be highly sensitive and highly specific, yet we do not have a biomarker which has both these qualities. And when we talk about AFC and AMH, I'm just giving you a small idea. There are 2 terms which have been coined for AFC as a predictor. One is follicular output rate, FORT. Now, what is this? For any given AFC, there is a potential oocyte yield, but it can be altered by the stimulation strategy, the presence of ovarian resistance to stimulation due to genetic polymorphism, or sometimes by also other factors. Now, FORT does not consider oocyte recovery. It only considers antral follicle count ratio to pre-ovulatory follicles. And what are the pre-ovulatory follicles? They vary between 16 and 22 millimeter in diameter. So it is pre-ovulatory follicle count on day of HCG multiplied by 100 divided by small antral follicles, which are 3 to 9 millimeter in diameter. So this is FORT. We've not reached the oocyte recovery stage. For that, FOI was coined, which is follicle to oocyte index, which is oocyte number divided by antral follicle count multiplied by 100. So if we get more than 50% of what antral follicles we saw in the beginning, then we say it's a normal FOI. If we get less than 50% of what antral follicular count was there in the beginning, then we say it is a low FOI. And both these appear to be equally important. FOI may be used alone or combined with FORT to most optimally reflect the ovarian resistance to ovarian stimulation. The result of FOI can also help to understand whether it is possible to exploit the ovarian reserve further by using pharmacologic interventions like maybe increase the dose of FSH, add LH, do anything else. FOI could also be useful to predict likelihood of success in ART, the so-called Poseidon marker of successful outcome, as well as pregnancy success. Technical aspects related to oocyte retrieval and triggering for final oocyte maturation can influence FOI results. So FORT is not influenced by triggering or technical aspects of oocyte retrieval. FOI is dependent on this also because it is the number of oocytes you've recovered, and hence if your trigger has not been sufficient or your pressures of retrieving oocyte is not sufficient, you might still get less number of oocytes. Whereas FORT doesn't consider the number of oocytes, it only considers follicles over 16 mm. Now we come to AMH. It's very interesting. You look at this graph and see that average total intra-individual AMH variability is 20%. Now you see every line over here, which is there, shows the intra-individual variability. The first line is at 10 picomoles, 5 picomoles, and 30 picomoles. So you can see and one can go to as low as 5 picomoles also. So this is intra-individual AMH variability. 1%, like if I get my AMH twice at 2 different times, I could have this much of variability, which is in the 20% range. And when you look at the range, it could be 2.1% to 73%. 23%. So AMH of 1 could show as AMH of 1.7 also at another instance, or it could show as 1.02 at some instance. Then there is a biological variation. This is a biological variation. Then inconsistency in AMH measurements is mainly of biological origin, but it is not so. It is also dependent on the diagnostic method used. Now, all assays are automated assays, and if we look at our data, we found that almost 30% women would have received an inappropriate dose of FSH if the Beckman-Coulter access assay was used. 30% of women would have received an inappropriate, means we get a high AMH and hence we use a lower dose, and in fact it was the Beckman-Coulter access assay, which showed a higher AMH. Substantial proportion of women, ranging from 49 to 90%, depending on the AMH category, would receive a lower dose if FSH based on the access AMH assay also, which is by Roche. Now, Roche and Beckman-Coulter have joined hands, and hence we get results which are more accurate, but yet there could be so much of difference. In high ovarian reserve, you get less of problems, but 25 to 10% of women with high ovarian reserve would have been misclassified to a greater dose of polytropin delta, that's FSH, based on the access AMH assay. So what are they doing now? Ultra-sensitive AMH levels are currently being developed, and their role in better discrimination and prognostication of poor ovarian response patients remains to be seen. So we are waiting for these ultra-sensitive AMH levels. Apart from these assays, which could give us fallacious results, there is genetic polymorphism, which we have started unrevealing now. And exogenous FSH consumption is higher in carriers of FSH receptor serine 680 variation or mutation and 5 beta LH variants in ovarian stimulation. And when they have investigated, they found that frequency of the FSH-R serine 680 variant is higher in patients selected as hyporesponders. Like good reserve, everything looks all right. Younger patients, you stimulate and you find that your response was poor. When we test them for genetic polymorphism, we find that FSH receptor genetic polymorphism is present. Similarly, for LH beta subunit also, a common polymorphic allele of the LH beta subunit gene is associated with higher exogenous FSH consumption. So both of these require higher FSH consumption. And we do not know, like we've now got a assay like AMH. 15 years ago, we had no AMH. So we used to rely on baseline FSH and estradiol. Now we have AMH. Maybe in a few years to come, we will also have a blood test for genetic polymorphism where we would get the result in a day or two. And we'll say, oh, you have genetic polymorphism. So her dose is going to be higher for FSH, even though the AMH looks all right. It's 2 nanogram, but we will still give her 300 units. So now let us come to the management of low prognosis patients. We'll separate the groups. Group 1 and 2 are the ones with a good reserve. But young one would have good quality oocytes, so less oocytes could be enough. Whereas the older group would have slightly poorer quality oocytes, and therefore we would need more oocytes. What are the possible reasons? One is asynchronous development. Number 2 is low starting dose of gonadotropin. Number 3 is polymorphism of one of the receptors, LH5 beta or FSH receptor, and trigger or OCR issues. So these are the 4 important issues or reasons which lead to or which bring about low oocyte collection. We'll go to them one by one. Why does asynchronous development of follicle happen on ovarian stimulation? Ever since we stopped the long agonist protocol, the use of long agonist protocol, which was the normal protocol till almost 2004 and 5, we stopped that because too many injections were being used, and we started the antagonist protocol. This problem started emerging. Why does it emerge? FSH elevation happens during the luteofollicular transition in some patients with poor ovarian reserve. Now, they have a poor ovarian reserve or they are slightly aged patients. And what happens as the progesterone level goes down with corpus luteum demise in the previous luteal phase, immediately FSH starts rising. And hence, few follicles are selected even before the menstruation ensues. And hence, when we give gonadotropin, those are more sensitive ones, so they just grow, and the lesser sensitive ones don't grow. And hence, we have a very unequal and small cohort. How are we trying to correct it? Pre-treatment. when we are using GnRH antagonist. And what are the drugs for pre-treatment? We can give estrogen in the luteal phase for 7-8 days in a ovulated cycle, or we can use oral contraceptive pills from day 2 or 3. So all patients with poor ovarian reserve or with a poor ovarian response in the previous cycle where the reserve looked good but the output was low can be started on one of these things preceding controlled ovarian stimulation, aiming to achieve endogenous gonadotropin suppression. So by giving these, we are just suppressing FSH, which is coming from the pituitary, and a uniform follicular recruitment and synchronization during the subsequent COS cycle. Then mid-luteal GnRH agonist long protocol is again our old is gold type of a protocol which synchronizes follicles but uses higher doses of gonadotropin from day 2 because endogenous gonadotropin does not support it. So asynchronous development of follicles, what is the treatment? Either use GnRH agonist long protocol. So there is a comeback of the GnRH agonist long protocol only to treat these patients who have possibly a good reserve or maybe a low reserve, but a very unequal cohort. Or we can use estradiol valerate 2 milligram twice a day from cycle day 23 till menses of a ovulatory cycle. This is a must. If you have not been able to determine ovulation or there is no means, please give her a progesterone withdrawal for the first 5 days of starting estradiol valerate so that she definitely has a withdrawal bleed within 10 days. Then OCPs can be used from day 3 for 15 or 21 days, and antagonist has also been used, though we don't use because it just increases the cost and number of injections again for the patients. But antagonist being used here will suppress the FSH and LH both. And hence, there would be no follicular recruitment as long as we are using antagonist till menses ensues. What is the treatment effect of dose adjustments in a subsequent cycle of women with suboptimal response? So here, suboptimal responders, you all agree that less than 9 oocytes is a suboptimal response. And with adequate ovarian marker who had the same stimulation protocol and used the same or higher initial dose of the same type of gonadotropin compared to their previous failed IVF attempts. So here, what did they do? They only increase the dose of FSH. And what did they found? That just by increase of 50 international units of FSH, they had a significant increase in number of oocytes, and that significance was 1 oocyte. So just 50 units more and 1 extra oocyte could be obtained in these cycles. So increase the dose of FSH by 50 or 75 units. Another one is add LH, recombinant luteinizing hormone supplementation, and this is most beneficial in patients with sufficient pre-stimulation ovarian reserve parameters that have an unexpected hyporesponse to FSH monotherapy. In all these cases, recombinant LH can be started either during the mid-follicular phase, like you find on day 5 suddenly a very poor response, you can start it then also to rescue the ongoing cycle, or it can be started on stimulation day 1 in a subsequent cycle. Another group which benefits by adding LH is women who are more than 36 years of age. So also we did a study, and this is the publication which was done by us, where we looked at effectiveness of recombinant luteinizing hormone, human menopausal gonadotropin, and letrozole. So what we used is either in a group we use recombinant LH, in another group we use HMG, and third group we use letrozole as additives to recombinant follicle stimulating hormone in women with poor ovarian reserve undergoing controlled ovarian stimulation. And conclusion was addition of RLH may improve the outcome of IVF in patients with poor ovarian reserve. Here it is, poor ovarian reserve during early stages of stimulation. So let us see what really happens. So how's the Poseidon management of low prognosis patients who have adequate AFC and AMH? So we go back again to group 1 and group 2, good reserve, but young patients, good quality, older patients, poor quality oocytes. Possible reasons we already stated: asynchronous development, low starting dose, polymorphism, or trigger and pressure issues in OCR. What is the individualized control ovarian stimulation treatment for such people? I've combined both of them because there's very little difference in both. One is if you're using an antagonist protocol, controlled ovarian stimulation, then give pre-treatment with either estrogen or oral contraceptive priming, or you change over to GnRH agonist long protocol. So antagonist needs a E2 or OCP priming in the pre-cycle, GnRH, or otherwise change to GnRH agonist long protocol. Recombinant FSH in place of urinary FSH or HMG, change the type, increase the recombinant FSH dose, add LH, then trigger you can change it to dual trigger and look at your aspiration pressures, look at the system, whether it is watertight or not. And if this is the older age group, group 2, where you need more embryos, there you can use duostim, 2 stimulations, or bistim. That means 2 stimulation cycles to collect embryos. Transfer strategy is not different for both of them. You can do a fresh transfer or a frozen transfer according to what you want. But look at the measure of success. In the younger group, minimum 5 mature oocytes are required to make 1 euploid blastocyst. Whereas in the older group, with the same reserve, we need 10 to 12 mature oocytes to make 1 euploid embryo. And hence we need more oocytes. So if you make 10 to 12 oocytes in one go in a stimulation after using the corrective methods in ICOS, it should be enough. But if they are less, then you will have to use a bistim or duostim. Let us go to group 3 and group 4. Now, all additives are used in these groups because they have a poor reserve. You cannot do anything about it. Whether they are young or they are old, their AMH is low, their AFC is low. So here, what are the reasons? Poor ovarian reserve is one reason that you've got less number of oocytes. Asynchronous development in these patients really becomes a high nuisance problem. And then there could be polymorphism in these women also, the young ones in the and the older ones both. So poor ovarian reserve, you can't change, but you could probably try to use adjuvants. And what are the adjuvants which have been advocated now? Which have some evidence to support their use as androgen, pre-treatment, growth hormone, pre and simultaneous treatment, and CoQ10 in women less than 35 years of age. In older women, CoQ10 has not been suggested to improve or to be used as adjuvant. And then what do you use? Either you switch over to long GnRH agonist protocol or you use antagonist with pre-treatment with estradiol or OCPs. Over here in this, they have not recommended the use of antagonist, but that is also there, which could be used. Start recombinant FSH, the starting dose has to be 300 units daily. All other cases, the starting doses would be according to their reserve. It could be 200, it could be 225, it could be 150 also. And if the woman is more than 35, please add LH 150 units with your stimulation. Just 75 units may not be enough. And 2 is again duostim, because here even the younger group, even the older group, both may require 2 stimulations. Again, for the younger group to reach a oocyte number of 4 to 7 to get 1 euploid blastocyst, in the older more than 12 oocytes for 1 euploid blastocyst. So if you get less oocytes, you will have to stimulate them again, whether you do a bistim, duostim, whatever you do, but you have to collect so many oocytes to make enough blastocysts so that out of them, one is euploid. This is a review of the Poseidon group, again published by the same group, that is Carlos Elvigis, Andrew Steves, and Peter Himiden from Brussels. And this was published in September 19. And if you look at the best practice in Poseidon group 3 and 2, where AFC is less than 5 and AMH is less than 1.2, if she's less than 35 years or she's more than 35 years, in both the groups, it depends on you whether you want to use adjuvant treatment or not. If you use adjuvant treatment, what are the adjuvant treatments in the younger woman? Androgens, growth hormone, CoQ10. If you don't want to use any adjuvants, you straight away go to either long protocol or antagonist protocol with pre-treatment with OCP or estradiol. Now, if the woman is more than 35 years, again, yes or no for adjuvant. Here, they've not mentioned CoQ, only androgens and growth hormone. If you don't want to, straight away stimulate them. Then, what is the stimulation? Well, 300 units of daily FSH in the younger age group. In the older one, 300 units of daily FSH plus 150 IU of recombinant LH also. I'm not going to detail chorefolitropin alpha because it is not available with us. And then later on, trigger and retrieval. If you use long protocol, the only trigger you have is HCG trigger. If you use antagonist, you can use GnRH agonist as trigger or HCG as trigger or both. If you use Diostim, then GnRH agonist is the trigger of choice. And then you look at your foci, you look at your port, and then you see whether you need to stimulate again. So this is the best practice in Poseidon groups 3 and 4. Just one word about Diostim. This protocol are best suited for low ovarian reserve patients, poor response in previous IVF cycles with less than 5 oocytes obtained, and when you need PGT of embryos to accumulate more embryos before sending them for genetic testing. Now, first time in the world, the dual stimulation was described as Shanghai Protocol from China. This protocol was developed by Professor Kuang and his team at the Shanghai Ninth People's Hospital affiliated to Shanghai Jiaotong University School of Medicine, China. This unit does 7,000 OCRs a year with 100% frozen thought cycles. That means every embryo they make, they freeze it, and then they do a replacement of the. Now, in this protocol enables 2 stimulations in 1 cycle. Here they've used a lot of combination of drugs. First stimulation is by using letrozole and clomid from the second day of the cycle for first 4 days. On day 6, letrozole is being replaced by HMG and then 150 IU every second day while clomid continues, monitoring to determine day of GnRH agonist trigger and egg collection. So they've not used antagonist. All embryos are cryopreserved. A second stimulation started 3 days after the first OCR. Again, letrozole and HMG is given every day. After 7-8 days of stimulation, the first ultrasound is done. And if the leading follicle is more than 14 letrozole is stopped. They have not described whether they've used antagonist or not, even in the second phase, but HMG continues same dose. Agonist trigger is given and egg collection 32 to 36 hours later is done. All embryos are cryopreserved. However, these stimulations were the initial stimulations where they tried to use minimal injections and a lot of drugs to cause ovarian stimulation. We adopted this from modified from Ubaldi's stimulation protocol from 2016. What we changed was that we stimulated the patient on the antagonist protocol only, gave her a GnRH agonist trigger and did a OPU. And after 3 days, we started the second stimulation, but this time we did not use an antagonist, we used progesterone. Progesterone, which we used was medroxyprogesterone acetate, but we've already discussed in the PPOS protocol that you can use dydrogesterone also. So that was used as 1 tablet daily. The only benefit of using progesterone over using an antagonist protocol in the second luteal stimulation was prevention of menstruation to happen in the middle of stimulation. Otherwise, most of the cycles where antagonist is being used, menstruation happens. And the original Ubaldi's protocol started stimulation from day 5, which we've realized now is a better strategy to start because by that time, you know how many blastocysts you have made in your previous pickup. And if you have made adequate, we can do away with duostim. Two, the requirement for gonadotropin is for lesser days. So we start MPA 48 hours after OCR till the second trigger. The second trigger ideally should be GnRH agonist and then OPU is done. But sometimes this continuous progesterone for 13, 14 days where the stimulation goes longer suppresses the LH to such an extent that we've realized in these cases a dual trigger may be a better option, that is HCG plus GnRH agonist. And we've used it for all our low prognosis patients, where after the first stimulation, we get less oocytes according to the Poseidon criteria. So our study has been published in Journal of Human Reproductive Sciences in 2023 July-September issue, where the conclusion was that in women with poor reserve, the addition of luteal stimulation could increase the chance of achieving a pregnancy by significantly increasing the number of eggs and transferable embryos per menstrual cycle compared to follicular stimulation alone. In every menstrual cycle, ideally only one follicular stimulation happens. But here, in one menstrual cycle, we are doing two stimulations, and hence we are gathering more oocytes and hence making more embryos. Furthermore, luteal phase stimulation in the same cycle proved to be an effective strategy to rescue Poseidon poor responders with no embryos after the first stimulation. It's very disheartening for a patient when we tell her that, we got 3 oocytes and you have no embryo, or we got 6 oocytes and you have no embryos. For such patients, if we can start immediately and they have hope that in the next 10 days we will get more oocytes and they may form embryos, it is very easy for them to go through a duostim. So this is what we found, that convincing patients for a duostim, if no embryos were formed or less were formed, became easier. And therefore, to summarize, synchronize follicular development on ovarian stimulation by using luteal pre-treatment. Whether it is agonist long protocol as luteal pre-treatment, you can even give luteal pre-treatment, stop it on menstruation, and then give an antagonist later on, or use estradiol valerate in the late luteal phase, or OCPs or antagonist. Add androgens, CoQ, and growth hormone pre-treatment in group 3 and 4. I do not add either of these uh, adjuvants. I have used androgens once upon a time and they had mixed results, but rest I have not used. If anyone has used in the group, can always come out with their experience. Increase FSH dose and add LH, or if cost is a restrictive factor, then maybe HMG. Dual trigger with agonist and recombinant HCG is where we feel that everything looked all right. The fort looked all right, but the foci became very little. Then it is best to give dual trigger. Check aspiration pressure and flow rate, presence of cumulus cells in the first few follicles. If he says no eggs, no eggs, then ask that are there cumulus cells or not. And duostim or bistim, especially duostim, because in one menstrual cycle, we can collect oocytes twice and have double the number of eggs and embryos both. So the real voyage of discovery consists not only in seeking new landscapes, but in having new eyes searching the old landscapes. Thank you very much.
Thank you for this wonderful lecture, ma'am. I now request all the participants that they can put their questions in the chat box and we can have a discussion one by one. Or if you want, you can unmute yourself and directly ask the question. So, ma'am, there is a question from Madhura. Ma'am, can you please once again explain the duostim protocol used at SGRH?
Madhura, you start your patient as a normal patient who's undergoing an antagonist protocol. I like to give pre-treatment and I use a lot of estradiol valerate in the pre-treatment. So even if she has a poor reserve or she had a poor response later on, pre-treatment is important. Once she has her menstruation, you stop the estradiol if you were using estradiol, and you would start the gonadotropin dose as you have calculated for her. Whatever doses, give an antagonist when a leading follicle is 14 mm or 13 mm. These are all poor responders, so we don't give a fixed
Ma'am, just one
protocol.
request. Can we go back to the slide where this protocol was shown so that we can
Yeah,
understand?
yeah, I'll do that. Yeah, there it is. So we normally start from day 2. You can see in the menstrual 4 days, day 2, recombinant FSH or recombinant FSH with LH. Whatever you've decided, you start. You continue to give. From probably day 5 or 6, you start the antagonist, looking at the lead follicular size, looking at the E2LH levels. And then once you've reached a status where you feel that you have the follicles which are in a size where you would want to trigger, then you give a GnRH agonist trigger. Here, agonist trigger is very important. And please understand that agonist trigger is really very good for these patients, because agonist trigger leads to lysis of the corpus luteum much faster. And so if you give a agonist trigger, you do a OPU 36 hours later, you give a 3 days or a 4 days gap where you are not giving any injections, but we start MPA 10 milligrams 48 hours after OCR till the second trigger. Why do we give medroxyprogesterone acetate? Because if the corpus luteum lyses, the menstruation may come within 8 to 10 days only. And if we are stimulating her, then also the menstruation will come while giving antagonist and while giving stimulation drugs. It becomes messy for the patient and also worrisome. So just giving MPA for 48 hours later, we just start MPA 10 milligrams, and you can start the stimulation 2 days later. That means from day 4 or day 5 also, depending on whatever your strategy is. If you have a policy of making all blastocysts, please wait till day 5 comes, and you will have a good idea of what is the blastocyst formation rate. Even if they are not ready on day 5, you know that a few of them will make us blastocele by day 6. So that is the day when you can start the second stimulation. Same dose which you've used in the first one. Here for 8 days, we close our eyes. We say you just go on taking the injections and you take one Meprate tablet every day. She normally doesn't get her menstruation. Maybe one breakthrough may occur in 100 patients, but mostly they don't get their menstruation. They continue with the injections, and by the time they come for the first ultrasound after OPU, already 8 plus 4 or 5 days have gone, which means about 12, 13 days have gone. So lysis of all corpus luteum has happened, and all follicles which you see are new follicles which are emerging. And that's it. And then you give them a trigger with GnRH agonist, or we don't mind even giving them a dual trigger, because in 1 or 2 cases, we realized that the progesterone which we gave and the stimulation was longer. Generally, the luteal stimulation is 2 days longer than the follicular stimulation. So if you've given follicular stimulation for 10 days, here it would go for 12 days, and 5 days you've given no stimulation to 5 plus 12, about 17 days. And hence, there is a very sometimes severe suppression of LH. So here you can give a HCG plus GnRH agonist trigger, or only HCG trigger, whatever you like. Because in any case, now you don't need to stop the corpus luteum lysis. So it goes very easily that you do a OPU after 35 hours. Madhura, could you understand?
Yes, ma'am, I understood.
You understood, no? So
Yes,
in the
ma'am.
second phase, we started this MPA only because a lot of patients would say, oh, we are bleeding during stimulation. Even we, as initial starters, got a little perturbed. Should we stop? Should we go ahead? And then we looked into literature and we said, just go ahead. And we changed over to MPA rather than giving them antagonists to suppress their LH. And estradiol levels have no value in the luteal phase because they're all mixed up values. Progesterone is high, estradiol is borderline, it's not too high. So you can just monitor by follicle monitoring in the second phase.
Yes, ma'am. Thank you, ma'am.
Okay.
Ma'am, Khushbu Goyal, Dr. Khushbu Goyal wants to know what is the role of follicular phase GnRH antagonist in the synchronization of follicles.
It is not follicular phase antagonist. It is the luteal phase antagonist, Khushbu. See, we are using estradiol to do what? Because progesterone is going down. The corpus luteum has already lysed of the previous cycle. Progesterone levels drop. And once the feedback, negative feedback stops, FSH will start coming from the pituitary to recruit new cohort of follicles. Here, when we give estradiol, then we are suppressing the pituitary to secrete FSH. If you give her progesterone, what will happen? You will delay her menstruation. We don't want to delay her menstruation. We want just the FSH secretion to stop in the late luteal phase, which will select her follicles much before her menses starts. That's all. So you give antagonist with the same purpose. instead of giving estradiol, you're giving antagonist, but then it is a daily injection, 0.25 milligram, which patients are not too happy to have.
Ma'am, there are some protocols which suggest that giving antagonist on day 1, 2, 3, then starting stimulation. And there are some centers which are following this. We'll have to look up
Bhavani, I
into the
agree. There are
evidence.
a lot of combinations,
Yeah.
permutations, and things which people use. But I'm talking
Hmm.
about standard protocols, which
Standard protocol,
can.
which says only luteal antagonist, not
I've
false.
seen even people using antagonist if LH is high on day 2. So, I
Yes,
mean,
ma'am.
we can try logically thinking that, we will suppress, but then LH high is now stopped being a bother to us because we know that LH high has an inherent effect on the whole oocyte cytoplasmic complex. And hence, just depressing the serum values will not take away that effect. Same way as if FSH is 30 and you give her OC pills and FSH comes down to 6, 7, you've not brought her ovarian reserve back to normal. It's just a virtual feeling that FSH is low and therefore you can stimulate, but she will still not respond because her initial FSH or is indicating that she has a low reserve and the FSH has gone high because pituitary is sending a lot of impulses to the ovary. Same thing is when we suppress LH also, we are only doing a visual cleaning of the LH levels. But in fact, with those high LH levels also, if you start stimulation and FSH supersedes LH, LH will drop naturally and FSH will take over to make a cohort of follicles. So antagonist has the same role.
Ma'am, Dr. Soumya is asking, while giving estradiol valerate as pre-treatment, is it necessary to have menstruation before going ahead with stimulation?
A valid question, Soumya. But you know what? If you've already planned that you're going to freeze all embryos, you might not. But menstruation is a sign that, yes, all the hormones have gone down, the steroids have gone down, and giving estradiol valerate, but you will not get menstruation if the patient has not ovulated. In that case, I told you that please give medroxyprogesterone acetate 10 milligram twice a day and start estradiol valerate from the day you finished medroxy. So that progesterone withdrawal bleed will happen, and all those withdrawal bleeding valid days may you have given estradiol to keep the FSH secretion suppressed at the pituitary because you've stopped progesterone. Now progesterone will fall, so FSH will start coming. So giving estrogen is just keeping the FSH in control. Who's this girl?
Ma'am,
DM का पूरा? Any role of intra-ovarian PR? Yeah, who is
ma'am,
DM? Can you speak up?
who has asked this
Anyway, there
question?
is a
Any
question
role
I
of
can see in the
Ma'am,
question box.
it's Divya Jain.
Huh?
Yeah, you can speak up.
Ma'am, any role of intra-ovarian PRP at the time of first pickup in divorce?
बेटे एक चीज आप बताओ, is PRP a option which is being agreed by everyone universally that it should be used? Are there any complications of PRP? There could be any side effects of PRP. These drugs like stem cells, PRP, bone marrow is still to be used in the research setting. So why do you want to use ovarian PRP? You tell me, what will it happen at the time of first OPU if we even put in PRP? What will it do within those? That we don't know, and I don't think that we could. We are supposed to treat our patients in a way where which happens long-term autoimmune reactions, even though a lot of people are using PRP intra-ovarian endometrial, but it should be done under research setting, not on a daily practice on patients. Only because it is available and it is cheap in our country, we don't really advocate injecting anything inside the ovary. I think we
Ma'am,
need to do a longitudinal study to see what is the incidence of ovarian cancer, what is the incidence of autoimmune diseases if we inject PRPs, and see what happens.
Ma'am, Dr. Madhura is asking that at our center we give follicular phase Estrabet 8 milligram for 4-5 days, then start antagonist protocol. How does follicular phase Estrabet help in synchronization?
I really don't know, Madhura. I'm sorry. I have no idea. At your center, if you are giving it, you put a reference in this forum. We all need to learn from each other. And if it has a logic in it, we will understand that, yes, this is a new thing which we've learned. But if it doesn't have a logic, then we will leave it as it is. Okay?
Okay, ma'am.
And Dr. Smriti Ray wants to know if there are cysts even after estradiol pre-treatment in low reserve patients on day 2. Can we give 3 doses of cetrorelix to suppress the follicle and then start the stimulation when the
Is it
baseline
a cyst?
estradiol is achieved?
If this is a cyst, it will not get suppressed by cetrorelix. Understand that. And if it is a overgrown follicle, well, it could, but I don't think that if it is a cyst and your basal hormones are normal, then this is not producing estradiol or progesterone. You can leave it alone. A cyst will not get suppressed by cetrorelix. Yes, if there is a true corpus luteum or follicle which is producing progesterone or estrogen and that is high, then it's not a great cycle to start any stimulation. There you can consider giving antagonist, but it can be given for 3 days if you find a cyst with high progesterone E2 levels or with normal E2 progesterone levels. Put it on the forum and we will look into the paper, the strength of the paper, the strength of the evidence which they are giving, and we will definitely change our protocols accordingly.
And Dr. Devyani wants to know that should be the LH in group 3 also.
Yeah, you see, LH is very controversial in poor reserve patients, whether this is group 2 also. I mean, group 1 and 2 are poor responders. They are not poor reserve patient. So if there is receptor of LH might help increase the dose of FSH might help. So there is no harm in adding LH in these cycles when you see a poor response on follicular scans. There is no harm at all. Whereas in the older group with low reserve, the dose of LH is important and maybe 150 units is important. Rest of them, maybe 75 units should be good enough. What is everyone else's opinion with the doses? Shalini?
You all can unmute yourself and can share your experience regarding addition of LH in poor responders.
So we can call off the meeting now. Bilateral dialogue in TAS is helping us to do that. They are giving us a platform where we can have a bilateral dialogue apart from the chat box. So just unmute all your. Mild stimulation, talking of conventional stimulations. But mild stimulation, you have to prepare the patient for multiple stimulations then, especially if she is more than 35 years of age, because you would need 10 to 12 oocytes to make one euploid blastocyst.
Ma'am,
Doctor,
it is about the
Is
ma'am,
it true?
Soumya. I want to
Yeah.
ask
about your opinion regarding the recent ART Act, which is directing us to pick only 7 oocytes, and so how are we supposed to get euploid blast if we are considering on the small numbers of oocytes?
3 points now here. One is that all your oocyte donors' age is young. And over there, it was 5 oocytes would make one euploid blast. Number two, the whole intention of the ART bill is to prevent overstimulation. And that is why they've given a number 7 over there. But the new addition came in that please aspirate all possible follicles which are there. The sad thing is that despite saying this, even today from donors are very, very good responders. They have children. They are generally in their 20s and hence tend to over-respond. So it is very important to have low stimulating doses, maybe 100 units only for them, because we've used 150 and we got 20 follicles, which is not right. Even today in conferences, people talk about 60 oocytes. So I don't understand that on one side, they are asking us lower your stimulation so that donors or young women do not have so many oocytes. On the other hand, we are still stimulating them with doses which give us a high yield. So 7 is a approximate number which they've given, but they've made an amendment in saying that aspirate all what you have.
Very good evening, ma'am. Ma'am, there's a
Thank you.
question,
Yeah,
but not related to this topic. Ma'am, actually, I had a patient. She was a thin, lean PCOS, and with mild stimulation also, she had with agonist trigger also, she developed mild OHSS.
right.
So, ma'am, do you have any clinical experience of using Letros throughout the stimulation to prevent OHSS?
No. Letrose doesn't prevent OHSS. Please, letrose only keeps the estradiol levels low, and estradiol levels are important in triggering OHSS, but letrozole use only keeps the estradiol levels low, and you can use 2.5, you can increase to 5, 7.5, even 10 in patients where we do not want the estradiol levels to go up. But OHSS is not prevented. It happens with the HCG trigger. So if you give a GnRH agonist trigger with whatever doses you've used of gonadotropin with letrozole, then you will not get a late OHSS. Early OHSS could be mild to moderate. It will never be more than that.
Okay, ma'am.
Who
Thank
was
you.
this? Was this
Ma'am, I
Garima?
have a
Ma'am,
question, ma'am.
Agitika. Ma'am, but there's a study. I have the abstract
Gitika, right.
now. It will be published in October 24, in which it is saying
Right.
that Letros up to 7 point, they have used up to 7.5 milligram, and
Right.
it reduces the incidence of OHSS, ma'am. The
It's a
study is
agonist
not yet
trigger,
out,
right?
but the
It's a agonist trigger, right?
yes, ma'am, to prevent mild
So
OHSS. I have the abstract of that study, ma'am.
very
Study is
nice.
yet to be
Very
published in
nice.
October 24.
Absolutely agreeable that letrozole keeps the E2 levels low. You can increase
Yes,
the
ma'am.
dose to up to 7.5 and give a agonist trigger, and it will only lead to, if any, is mild OHSS. Not very nice. I'm very happy that you are working, Gitika, and you are
Thank you, ma'am.
doing writing research work also.
Ma'am,
All
I have a
credit goes to you,
How,
ma'am.
Ma'am,
Thank you,
I
ma'am.
have a
yeah.
question. Ma'am, one of the strategies proposed for poor responders is increasing the dose of recombinant FSH. But ma'am, if we see the Poseidon group 4, in many of the studies, it is also said that increasing the gonadotropin dose can compromise the oocyte quality. So ma'am, then how should we go about in such situations?
Increasing the dose when they say the maximum dose is 300. So if you are starting with 225, increase it to 300. Nobody in the world suggests a dose greater than 300. Maybe whenever you suspect polymorphism, you can increase by 35 or 75. But if you give her 600 international units, where do you think follicles will respond to? So there is no use in increasing the dose to such levels. All what you can do is increase the dose by 75 units only. Add LH, looking at the age 150 or 75. That's all about it. It will not compromise your quality. So please remember, when we say increase the dose, don't take it over 375. 450 is a very high dose. I have never used that dose in my life. I don't think any of my team workers, there are so many over here. Gitika is here, Bhavani is here, Tejasvi is here. 300 has been the maximum which we've used. Yes, we have added LH 150 or 75 to these patients. When we give Pergoveris, it has 300 units of FSH and 150 units of LH. So that is okay. But when you increase the dose, maximum by 75 units, not more than that. Okay?
Thank you, ma'am.
Yes. Do we finish, Bhavani, Tejasvi?
Yes, ma'am. We are done with the questions. Thank you so much, ma'am.
Thank you, everybody, for giving
Thank
me.
you so much,
Ma'am, I
ma'am.
really admire how you take so much effort to make the presentation so educative for all of us. Like, it's really amazing to see you
Thank
work
you,
so hard
Tejasvi.
for
It
us.
is
Thank
also
you, ma'am.
educative, very educative for me also. I revise all the strategies. Ask Bhavani, I was reading about CoQ and growth hormone today morning
Yeah, you were
to see what
mentioning,
are the
so
doses to
I
be
was
used, how
waiting
to
for somebody to speak about growth hormone in
Yeah,
case they've used
because
it in
I
their side.
already clarified that I've never used it, but CoQ
Yeah.
doses are not written anywhere. They don't write 300, 200, or 100. All they write is
Yes.
CoQ10, one tablet a day for 60 days before treatment,
But
before
if anybody
PCOS.
does have any experience about using growth hormone routinely, we would like to know more about that.
Yeah, yeah. But I think, Tejasvi, this still is in the research setting. I was
Yes,
reading
yeah,
after the latest
adds to the
Cochrane
cost a
review.
lot. Yeah.
Yeah, after the latest Cochrane review, which, gave us a double-sided answer, I was reading a
Hmm.
2019 article on growth hormone where they started 2 units of growth hormone daily from day 2 or 3 of the previous cycle. They gave it across COS till HCG trigger. And they say that
Okay.
only when you give it for such a long duration, it could probably lead to some changes in giving you better oocyte quality and numbers also. So these are individual studies, and even the meta-analysis review is quite lopsided, but the latest one in 2018 did say that growth hormone helped. There were 8
Correct.
studies in which 5 showed it helped and 3 showed it did not help. But the overall numbers on the 5 side was more, and so the diamond came onto the right side.
Right.
We still need to learn more about growth
More
hormones,
about it. Yes.
and its use, because it adds one injection and it adds to the cost tremendously. And if we just get one extra oocyte is not
Extra
helpful.
side.
It's better to go for a double stimulation and get that extra
And ma'am,
oocyte.
there's no
Okay.
consensus on the dose and the
No
protocol
Yeah,
consensus
for
all
and the
studies
growth
have
duration.
used
hormone.
different doses.
Start. When to start, whether you start with the stimulation, before the stimulation, in the mid-cycle, all studies have shown different doses, different durations of use of growth hormone. Androgens, yes, everybody is clear that you use either gel or patch. Use it for short durations, use it before you start stimulation. So you can use it till day 1 and 2 of menstruation also for 20 days. So,
And regarding
androgens, I
DHT,
think we
yes,
should
we are
do something. Androgens, we should do something about it, do a research paper for that to see whether it helps or not. We'll take it up one day. Someone will come and take it up. Thank you. Thank you,
Thank you, ma'am.
Tejasvi.
Thank you so
Thank you,
much. Good
Bhavani.
night.
Thank you
Thank you, ma'am.
all the delegates. I'm so glad that so many people still have interest in learning sort of simple things by evidence-based medicine. Thank you. And where are in TAS people?
Good evening, ma'am.
Good evening. Thank you so much, Girish.
Ma'am,
And
good evening. Sanjay is there.
yeah, Sanjay, thank you all of you for being there.
It's our
And
pleasure, ma'am.
Mr. Dave is there
Thank
also.
you.
He started the whole program. I'm really, really grateful for you all for hosting this for us. Thank you so
Thank you,
much.
ma'am. Thank you.
Thank
Thank you so much, ma'am. Thank you so much.
Thanks.
Hello.
Huh. Someone wants to say anything? Sanjay Barik? Anyone wants to say anything? Manav?
No, ma'am. Thank you so much, ma'am. Thanks a lot, ma'am.
Okay,
It was
thank
a
you.
wonderful academic week.
Yeah, thank you. So next Thursday, we'll give you another topic. And if anyone has a suggestion, can put the topic on the forum and we'll take up the next Thursday thing again. Bye
Yes, ma'am.
bye. Good night.
Bye, ma'am. Bye, bye, ma'am. Good night.